All right. So here we go. We're basically covering prevention, and my objectives are to review various stages of prevention. You're reviewing the United States Preventive Services Task Force. That's the thing I really want y'all to pay attention to. That's where a lot of the board questions will come from on cancer screening, cardiovascular, diet, exercise, and a lot of behavior. So there will be questions on this. I've said several times you really want to review it, and I'll show you a couple of slides about it. I'm also going to focus on board relevant material. So with this, we're going to start off with a question. Which of the following programs would be considered secondary prevention? A microalbumin screening for diabetics, a condom distribution program, a blood pressure screening in a local church, or a middle school health class emphasizing reasons not to smoke. Okay, so as you look at that, obviously we haven't talked about anything yet, but here you go. Blood pressure screening at a local church is considered secondary screening. So we're going to talk about some of these things and what they mean and how how to best answer some of these questions as we go forward. So stages of prevention, primary prevention, and this is usually talking about cardiovascular health, but it's intervening prior to the onset of disease. And so with cardiovascular health, it's really particularly important because it relates to events. You didn't necessarily prevent hypertension or diabetes, but you did. You're trying to come in before you have a heart attack or a stroke. Things like diet modification, immunizations are part of this process. Secondary prevention is, depending on what you're talking about, could be intervening after you have the disease onset, but prior to symptoms like diabetes or hypertension. Screening tests are often in this area, pap smears, mammography. Again, in cardiovascular, and a lot of board questions and a lot of discussion will be about cardiovascular health. So primary prevention for cardiovascular means before an event happens, not before hypertension. Secondary prevention for cardiovascular issues is after you've had an event, heart attack, bypass surgery, stenting, stroke. This is important because, for example, with statins in cardiovascular health, primary prevention, statins have morbidity data, but not mortality. However, after an event, secondary prevention, statins, you don't even do the calculation. We've got enough mortality data, you want to start it. So that's why that distinction can be important. There's also tertiary prevention, and this is intervening, and I put prevention in quotes because obviously you didn't prevent it, but you're intervening after symptoms have appeared, and you're trying to prevent further progression and complications of the disease. So, for example, beta blockers or statins post-MI, although again, that's also in secondary prevention based on cardiovascular health, but another way of looking at it can be tertiary, lowering hemoglobin A1C, but in that case, that's also a surrogate marker because that's not outcomes data, that's just a number. When you look at that, this is another way of seeing that onset of disease, primary prevention before you have the disease, secondary preventions where you really get to symptoms, and tertiary is onset of symptoms. So this is really better for something like diabetes or hypertension, and cardiovascular health is usually just primary or secondary. There's also another thing you can consider, which is quaternary prevention. That's protecting patients from the negative effects of the overuse of healthcare interventions. And this is really important because there's a lot happening right now, and a lot of things will pop up probably on boards along the lines of not doing unnecessary testing, not prescribing antibiotics for viral illnesses like we talked about before. There's a program called Choosing Wisely. I don't think it'll be on the boards, but it's worth knowing about because it's really a way of pulling a lot of this together. And for example, here's a picture of Choosing Wisely. There's an app for it. Again, you can't use that on the boards. This is really more for your knowledge. If you just Google Choosing Wisely, you'll basically find great recommendations for what you should and what you should not do based on a lot of different conditions. Preventive services, in a lot of ways, we're preaching to the choir because you're family docs, you understand it. This is what we do. We save lives. 800,000 preventable deaths per year from diet, tobacco, alcohol alone. It's less costly to treat early and you have better outcomes. Unfortunately, we have societal challenges because we don't have support for this effort. And it's hard to prove prevention in a lot of ways, but we're really still a reactive healthcare system, even though we all understand how important prevention is. So part of our challenge when we're doing well exams and Medicare wellness, uh, the reimbursement is that we're really trying to sneak this in at the same time we're managing all the other things that we're managing, the complaints, psychosocial issues, social determinants of health. It's really not compensated properly. It's also not as respected, even sometimes among healthcare, among our patients. So there's a lot of recommendations, and it's really challenging. This is reality. There won't be a board question on that necessarily. Although there have been some suggestions a board question can be, if we're going to do every recommended preventive exam on a patient, that can take over 20 minutes just to go through that, which is more time than we have scheduled routinely for visits. So there is documentation to show prevention takes time. So one of the issues here is, who do you going to trust? The physician barriers are difficult because of beliefs and knowledge. We have the patient barriers, same thing. And as I said, the system, we've got all this information systems, different approaches. Some electronic records will help you, some do not. You've got apps, then you've got all the conflicting recommendations. So the reality is this is hard, even though we understand it. And when you actually look at your own data, we don't do as well as we think we do. I think we all believe we do breast cancer screening or colonoscopy well, but if you actually evaluate in an objective way what you do, more often than not, we find out we're not doing well because of these barriers. So recommendations, they can come from the American Cancer Society, the CDC, medical specialty like ACOG, American College of Radiology, NIH groups, and the United States Preventive Services Task Force. This talk is going to focus on the Preventive Services Task Force because a lot of board questions from that. CDC often corresponds to it. It's a standard routine place that people go. It's what the AAFP often looks at. And so the ABFM pays attention as well. It's an independent panel of experts in primary care and prevention. They systematically review the evidence in terms of effectiveness and then develop recommendations for clinical preventive services. There's 16 volunteer clinicians from primary care. 7 of them are family physicians right now, and they're on 4-year terms. That's the link. This is where you go when you click the link. And again, this is more for your knowledge. If you haven't gone here, you should. And before you take your boards, you should go here and look through the information for health professionals aspect. What you'll get in those recommendations, you've got published recommendations. They'll give you the topics and you can search for them. They'll tell you whether it's screening, counseling, preventive. They'll give you the year and age group. And you can block this off and filter it based on what you need. But it's a great resource and one that a really good electronic record taps into this. You can also see recommendations in progress as well. When you click on some of these, like colorectal cancer screening, release date 2008, this is being updated. So you can go and see what the update's happening. But you can also see where you're getting certain recommendations. And we'll talk about A, C, D, and I, but just briefly, A means you better do it. D means you better not do it. I means we don't know yet. So being aware of those recommendations, because board questions will often ask about these, not telling you A or D, just figuring out, have you paid attention? Are you aware? There are apps for this. This is a great thing to have on your phone because you can quickly access, even in the patient room, just tell them what you're doing. Hey, let's take a look, see what's appropriate for you. And there are a lot of different aspects, including calculators and guidelines. So let's look at these. This is really what we're going to be paying attention to. They tend to be a little conservative, but they're very evidence-based. Well, by the way, when I say conservative, that's not really a political comment. They don't make sweeping radical changes without compelling evidence. That's what I mean by conservative. They're like very cautious about some of these things and really looking for evidence. For example, lung cancer screening, initially when the American Cancer Society came out and said, hey, we need to be screening some patient groups with low-dose CTs, the AAFP was really cautious about that. And the Preventive Services Task Force was a little cautious about, is that really an appropriate screening test? So conservative in approach, based on evidence, frequently updated. And the categories are going to be screening, preventive medications, and counseling. There was also the strength of recommendation taxonomy. That's called SORT. Occasionally a board question pops up relating to that. So your awareness of what that actually means is kind of important. So A means recommendations on consistent good quality evidence. So you should do it. B, based on inconsistent limited quality, but it is patient-oriented evidence. So it's probably worth doing, but not as strong an evidence as A. C, often based on consensus, expert opinion, usual practice, disease-oriented evidence rather than patient-oriented, various not high quality approaches. So C, you're not usually expected to do it. By the way, most board questions are going to focus on A and D, and sometimes B rather than C. So the U.S. Preventive Services Task Force sort of expands that SORT taxonomy. So A is the one that says, yep, improves health outcomes, benefits substantially outweigh harms. B for U.S. Preventive Services Task Force basically says that it's fair evidence that service improves health outcomes, concludes the benefits are good. C, no recommendation. So remember, C before was kind of up in the air. In this case, C is not making a recommendation. There's reasonable evidence that it can improve health outcomes, but they're not so sure about it. D is recommending against, and that's fair evidence that service ineffective or harm outweighs benefits. And they've added I, which is evidence insufficient. And that means there's evidence is lacking. Different than C. C has fair evidence that it can improve, but it's the balance is too close. I means there's not great evidence. It's poor quality. It's conflicting. Can't really tell. So I is a very different category. So we're going to go through a whole bunch of these. They're going to sort of overlap with some of the other board review topics. They're going to be maybe some differences here and there. Don't freak out too much. For the most part, what I'm providing is updated for the Preventive Services Task Force. They're high yield. All these things are things that are tested. So having a comfort with these topics is important. Colon cancer, screening ages 50 to 75 is A, do it. 45 to 49 probably worth doing, and colon cancer screening has been changing based on a lot of new evidence, but this is still current guidelines. And then 76 to 85, there's not enough evidence to be, or not enough to say that benefits outweigh harm. So that's a C recommendation as you get older, and you're kind of individualizing based on your patient. The Preventive Services Task Force does not recommend specific methods. There was a D recommendation for screening greater than 85, but a lot of our patients are at a better age, and we didn't want to. They didn't want to have a D automatically just based on age. So that recommendation was changed, and now it's sort of again up to individualizing care with your patients. They've not yet followed some of the GI guidelines. There's been a suggestion that African-American men should be screened starting age 45. That is not yet part of United States Preventive Services Task Force. And this is that challenge. Different guidelines will be different. So fecal tests, the fecal occult blood annually. One is the fecal occult blood test, which tests heme portion. The FIT tests the globin portion, higher sensitivity. Only 1 or 2 samples needed, but it only looks for blood, and hemoglobin can be degraded. There's the fecal DNA testing now every 1 to 3 years, which has higher sensitivity, but more false positives, but lower number needed, 166 versus 208 in terms of screening to stop one case. And that's a single stool test. Direct visualization in general, colonoscopies every 10 years, CT colonoscopy every 5. I know not everybody has that available. Flex Sig still is being done, especially